Hello, everyone, and thank you for joining. This is Dr. Ilabasi from 3D Diagnostics. First of all, I'd like to wish you and your loved ones all the best in health and wellness. We have organized a series of educational webinars to learn more about all the steps of computer-guided surgery and how we can make our guided implant surgery and implant practice a less stressful and a more efficient and a more successful one. Please check our website, 3ddx.com, for more information about our webinars. Now, a few technical points regarding today's session. A code will be given at the end of today's lecture for 1 CE credit, and you can enter this code in the following website, 3ddx.com/CE. Also, please feel free to add any question you would like to ask in the Q&A box, and it will be either answered by one of the panelists during the session or by Dr. Engel at the end of the session. Any unanswered question will be answered by Dr. Engel himself and sent to you by email within a few days. Now, today's webinar is the Introduction to Computer-Guided Surgery. And we are so fortunate to have our presenter today, the founder and president of the Engel Institute, diplomat of the ICUI, a pioneer in education of implant dentistry, one of the most knowledgeable super GPs in the field, and my personal mentor. Dr. Todd Engel, please go ahead.
Thank you, Frank. Hello, everybody. Let me turn down my microphone. Well, first of all, what a difference 20 hours makes. Yesterday, I was doing a webinar on how to be in the moments that we're going through. So first, let me also wish you and your families the very best. This is a time that we're all experiencing together, which is kind of unique, but we're all here together to help each other through it. So with that said, I want to first thank you for picking me today to spend the next hour and 15 minutes with. We will definitely make it very interesting and helpful. This is a basic guided surgery program. So if you're doing guided surgery, the basics are beautiful, as we say. You can't get away from basics. As long as you stick true to the basics, you'll be in great shape. For those of you who have not done guided surgery, this should be a good liftoff for you. I look forward to helping you. I'll show you ways that I will be able to help you beyond this webinar. Again, thank you, and I wish you my best. A lot of what you're going to see is subjective. And what I mean by that is I tend to teach, well, I do teach very agnostically, which means that I'm going to teach you how to do guided surgery regardless what implant you choose, what CBCT you have, what guided surgery kit, regardless. This is about how to do guided surgery. That being said, I wanted you to know that I have donated my time. There is no financial remuneration from anybody for this webinar. It is my pleasure to spend my time doing what I love to do with the people that I love in my profession. All right, so let's move along. Okay, so I just have this up here. After the presentation, there's two ways that you can get a hold of me. We will be doing a Q&A at the end, okay? I'm going to hurry through this the best I can, but I don't want to skip over any important points. At the end of this presentation, there's two good ways to get a hold of me. You can Instagram me at Todd Engel DDS, or you can send me a message through Facebook, Engel Institute Dental Implant Training. It's much easier than emails right now, as we are getting COVID emails to death. Underneath that, you'll see CEs, and you'll see some instructions about how to get your CEs. I apologize. This will again appear at the end of the lecture. I'm sorry. It'll appear at the end of the lecture, and you'll also be getting a code. Okay. All right. So, just a tiny bit about me. I live in North Carolina. North Carolina is beautiful. On the left, you'll see where I am right now. I'm actually in my home. I live right across the street from a lake. It's very peaceful, very tranquil. I spend about 26 to 28 weekends a year on the road. And when I come home, this is a perfect place to be. On the right, you will see this is the foyer to my institute. I also have a private practice. I am a GP, as many of you have known or know, and my practice now is actually limited to surgery. So I don't work on teeth anymore. I only do implant surgery and, of course, restore all my own cases with grafting and all the guided bone regeneration procedures, as well as soft tissue procedures. Okay. A little bit about me, really. Thank you again, Dr. Frank. As it says here, I limit my practice to implant surgery and prosthetics. I'm a diplomat of the ICOI, and we have well over 1,200 documented cases thus far as it relates to guided surgery. Now, for those of you who have heard me speak before, I'm a GP. I'm very tough on results, and I say that because as we get through this guided surgery lecture, it's really important that we understand that despite using a guide, or despite being a general dentist, if that's what you are, you become a surgeon as soon as you lift a drill into somebody else's mouth and place it within their jaw. You'll notice here surgical GP is blinking. And the reason that it's blinking is because the surgery is in your hands. It's up to you. So we are going to talk about this A to Z as quickly as I can. We are going to, again, remain agnostic about this, meaning I'm going to get to points where it's going to be specific to a certain implant, a certain kit, a certain guide, keys, keyless, etc. And at that point, I'll explain that we're going to kind of break away and go to the next topic that would be pertinent for everybody doing guided surgery. So here's an agenda of what we will be talking about, some of the benefits of guided surgery. We will go into acquiring data. How do we acquire data to do guided surgery? And then once we have the data, what do we do with it? How can we transfer that data? We will then go into a couple different things together. One will be nomenclature. What is the name of all this stuff that we're using? The keys, the guides, the handles, the dots, the lines, the drills, etc. And then we'll go into guide design. Guide design is all predicated on what you give the guide maker, whether that's you or 3D Diagnostics or anything else. Much like your crowns, you give a lab a really nice margin, you're going to get a really nice crown. So it's imperative that we focus on that as well. Guide design, it's not arbitrary. It's all by algorithm to make your surgery as easy as it can be, namely access. So the algorithm will give you the shortest distance to perform your procedure that you need to perform in the mouth without having opening limitations. Now, you might get to the point when we get into surgical design where you have the option. We're going to talk about flapless or punch technique and how we decipher between those two as well. Now, we're going to get into the surgical execution of it. How do we actually perform the surgery? And then through the whole thing, we're going to do case presentation and pitfalls. Hold, please. Thank you. Okay, I love this slide, and I'm going to share it with all of you now. As you see here, it's a Google Maps slide, and if you notice here, this is where my office is, Center Lake Drive in Charlotte. And if I leave my office and I want to jump in a car, or jump in an Uber, or jump in anything and get to Charlotte Douglas Airport, in order for me to get there, there's two pieces of information here that I obviously have to provide Uber or Google. It's where I am and where I'm going. Once I am here, then I get directions on how to get here. It's that simple. You all have done it. You all have used Uber or Lyft or whatever it may be, rideshare. And this means a message is coming in, and I want to make sure that, that there's no issues with video. Okay. So in order for you to get to destination A, you have to tell them where you are. And this is the same not only with guided surgery, but this is the same with surgery or dentistry in general. When we know the end result, then all we have to do is navigate with our intelligence, with our equipment, with our surgical intellect, our technology, and we can get there. But you have to be able to see the end result. The other thing I'm going to get into is how guided is not guaranteed, folks. Okay? Guided surgery, we're going to talk about when I use it when I don't use it, and why I make these decisions. Okay, here's a picture of me. Not that I felt the need to show you a picture of me, but this is one of our classes where I'm doing a demo surgery. But the reason I put this picture up here is not for the notoriety of the picture. It's to show you that I have 2 letters after my name that many of you do, or 3 letters, actually, a GP. And you're going to see this blinking here again. And the reason I have it blinking is because when you start something like this, when you go into somebody's mouth and you perform something like this, you are a surgeon. Yes, you may not have oral max after your name. You may not have perio after your name. I get it. But you are held to the exact same standards, guided, freehand, or otherwise. It's you against world. And I just want to caution you on this, because there are many out there, quite frankly, that think that guided surgery is guaranteed, which brings me exactly to my next slide, okay? Guided surgery should never, ever, ever replace knowledge, okay? Guided surgery is to help facilitate the strategy. And I'm going to show you exactly what I mean. So in a certain case where I might have narrow bone, I could do it freehand. But maybe the movement is limited. Maybe the prosthetic demands are of that, the implant needing to be exactly in one position to pull off the prosthetics correctly. And I'm going to show you what I mean with one that went south on me in a few minutes here. So keep this in mind. It's there to help you facilitate the strategy that you already know how to do. In other words, if you were going to hop on a bus to go downtown, you know how to go downtown. You've just chosen to take the bus instead of the car. Okay, so this is to help facilitate it. This shouldn't ever, ever replace either knowledge or confidence. If you come to one of my courses and you say, I want to do everything guided, this is a concern for me. This is a big concern. This tells me a lot. You should not feel this way. This is a guided surgery webinar. And I'm here to tell you that the approach towards guided surgery should be to help facilitate it for you, not to do it because you don't know how. All right, let's get into the benefits of guided surgery. And there are several. I'm just going to give you a couple. We have obviously the accuracy. And you're going to notice that everything is asterisks, and there's a reason. Predictability, certainly. Oops, sorry, got my chat on here. Comfort, yes, very, very much so. We can do full arch procedures in under 20 minutes. That's very comfortable. We minimize the interruption of the blood supply. We limit the amount of flaps. We limit the amount of surgical penetration in the bone. We limit a lot of things, and to the patient, that's equivalent to being more comfortable, less medication, less ice, less downtime. So this certainly is more comfortable. Time efficient. I'm not one that believes in looking at time as a measurement of money, meaning how to be more profitable as it relates to time. Do you know how much time this has taken you? And if you can break that down to dollars, here's what it means. I'm not a fan of that thought process, okay? We are not attorneys that bill by every 15 minutes. We're doctors that are supposed to achieve a result. Now, with that being said, I really love doing a full arch case in 24 minutes instead of 2.5 hours. So while I don't look at it like it can save me time, which can save me money, I look at it like we can get through this a little bit quicker. Now, I said that these all have asterisks, and there are many other benefits to guided surgery. These are the main ones. And I say possible down at the bottom with asterisks, because you can look at this guy that you're seeing right in front of you on the screen. And even though it's one single implant, the accuracy could be off, the predictability could be off. It could be very uncomfortable for a patient should that guide rock and you perforate through the facial plate. And for time efficiency, that's out the window, because now you're looking at a few procedures to fix it. I want to thank you all again for being here. I know that we have quite a group. We have almost 400 doctors and that are registered. And if everyone can hit mute, that would be great if you're not already muted already. Okay, thank you guys so much. Okay, so let's go ahead and look at acquiring data. Now, we do different types of guided surgery procedures, as we're going to get into, and they require a little bit of differentiation between the strategies. So let's look at that. Okay. When I started guided surgery about 12 years ago, I was one of was one of the very first GPs to do this, and it was in California about 14 and 15 years ago. And it was much different then. We had to take 3 scans, and I'll explain it in a minute. You had to buy your own software, which averaged about $12,000 to buy. And you had to figure out a way to do it, and you had to figure out a way to design it, and then you had to figure out a way to have it milled. We've come a long way. So now what we do is we talk about, those of us who are speaking about guided surgery, something called a dual scan protocol. So we went from needing 3 different pieces of information to 2, which is great. We also went from being from the need to buy the software, which was a pretty penny, to being able to essentially rent it, like we're going to talk about today, calling up a company like a 3D Diagnostics and borrowing their time, so to speak, and their knowledge and paying a fee for it, which is tremendous. So the investment is pretty much nothing. If you don't need it, you don't use it. If you don't use it, you don't pay for it. And in reverse as well, right? So there are 2 files that we are going to need, regardless of which type of case that you're going to do, okay? One is going to be what's called a DICOM file, and the other is going to be an accurate, planned, final prosthetic outcome. And I will tell you that right now, this is the biggest thing that's haunting and hurting many GPs who are not familiar with this, who are attempting to do all-on-X procedures. This is the demon that is after you in surgery. So if you remember just a few things through this whole lecture, this is definitely one of them. You must know where you're going to end before you start. Everything is predicated on incisal edges and tooth position. Now, the second file is something that we refer to as an STL file, which we'll get into. So let's look at a DICOM file. What is a DICOM file? What does it mean? Well, in short, it's a lowercase .dcm. So if you see a file come across your desk or by email and it says .dcm, that's a DICOM file. And what that means is digital imaging communication of medicine. Now, when you take a CBCT, and I would like to just remove any myth, any CBCT will work, okay? Any CBCT will work. When you take a CBCT collection, or a data set as we call it, you're going to get multiple slices of that human being pushed together like an accordion. Each slice that you're looking here now, you see 9 slices, 3 horizontally and 3 vertically. Each slice is referred to as a .dcm. So if you pick the one in the middle, and we decide that we want to look at the middle square that's kind of highlighted in orange, and we're going to place an implant in that, that is a DICOM file. That is a slice of the jaw in that particular spot. It is a paper thin slice. If you go to the right or go to the left, you are moving a slice in each way. But this is called a set. So I refer to it as almost like your file cabinet. You're going to put all these pieces of paper together, and you're going to smush them together, and you're going to store them. Okay, that's called a DICOM file, and we'll get back to that later. Now, obviously, as you all know, you all have been very, very privy to CBCT. I remember when I started speaking about 18 years ago nationally, very few people had digital sensors. Now everybody has a digital sensor, and now 2, 3, 4 years ago, GPs were starting to get into CBCT. As the prices were coming down, the fields of use were expanding for the money, and so now most of you are actually either in it, looking to get in it, or very close to that. And if you have any questions about that, this is not a cone beam lecture. However, if you reach out to me on Instagram and you have any questions, I'll be straightforward with you, and I'll tell you why I do what I do and the image that I use, okay? Now, the great part about this, and especially if you want to explain this to your patient as to why this is needed, if you look at a regular image, right, a periapical image, you have inferior superior and you have mesiodistal, but you don't have buccolingual, as you know, you don't have palatal facial. That's the whole benefit. So if we look at the bottom screen, we're going to refer to it as the axial view. That's head to toe, up and down. We can go anywhere that we want up and down in the skull. Coronal, which is the center view, has the blue square attached. We can go in and out. This is a very good view if we're assessing the border of the sinus or the inferior border of the sinus, so we can actually determine how we can place our implants and where they'll be more safe. And then, of course, in my office, the most often used view would be the sagittal view, and that would be the buccal, lingual, or the palatal facial width to design our implants. Okay? All right. So now, as we gather the CBCT, by the way, guys, a little off the record, if you have CBCT machines, I want to give you a little pearl here. My recommendation to you is charge as minimal as you can for your CBCT scan. The idea is not to make a living off CBCT scans. The idea is get them in the machine so you could have something to discuss with them that's very independent and pertinent for their own need. I charge $175, and we have very, very, very few rebukes, if any, on not being able to take a CBCT scan. I want them in the machine because, as you see here, if they're in the machine, I can speak to them and I can show them. And many people learn this way. Our objective is not to have our CBCT scan fee so high priced that we push them out the door. I feel that $175, if they can't afford the CT, then they can't afford an implant. Okay, all right. Now what we're looking at, back onto the implant stuff, is we're looking at two different CBCTs. We're looking at a partially edentulous CBCT, and we're looking at a fully edentulous CBCT. Now, guided surgery is approached two different ways depending on what presents. So let's get into that. Okay, so back to the dual scan protocol. Regardless of what case you're doing, 1, 2, 4, 7, or full arch, this is all dual scan. You need 2 scans. So we're going to take the DICOM file, and I'm going to explain how it's going to differ in terms of when you're acquiring the data, okay, from someone who has teeth versus doesn't. Now, if you're asking questions, we will populate the questions, but I'm going to stay on my groove here. So that way at the very end, we can go back to the questions, okay, and we will get to them. Not all of them, certainly, but many of them. Okay, now the second part of the scan, so the first scan is the DICOM file, and the second scan is going to be the accurate planned outcome, which we refer to as the STL file, or stereolithography file. So now we have 2 files. We have a DICOM file, which shows us the black and white, and then we have an STL file, which shows us the white and the pink. Hope this makes sense, and we'll get into this more. Okay, so here we are. We have a fully edentulous plan, and we have a partially edentulous plan. So let's start with something easy. By the way, I do want to make a recommendation. If you are just putting your toes into guided surgery, my recommendation is that you start with singles and doubles, and that you get a guide like you see on the right side where you have a lot of tooth support. This is a much more accurate guide, especially for the beginner, okay? But we'll get into that. So we're going for purposes of separation, we're going to call partially edentulous anything that has 4 available implant sites or less, okay? And then we'll treat fully edentulous a little bit differently. But nevertheless, they're both dual scan protocol. Okay. All right, so now the STL file for a person coming in needing number 5 or needing number 3 and 5 goes like this. The first thing is obviously we're going to take the scan. For the STL file, we are going to capture that one of 3 ways. We must have 2 files, remember, okay? Now, for the STL file, this is going to represent the mouth, or what will be the mouth if you're going to restore the entire mouth. And we could do that a couple of different ways. Number 1, we can take a really nice impression. This needs to be with PVS. I want to say that again, because that's going to be a question, and it's always a question in my courses. Any really good PVS material will do the job, okay? For the purposes of this lecture, I'm going to be brand agnostic. I'm not taking any money for anything, therefore I'm not going to favor anything. But at the same time, I want to let you know that whatever you are using will work. So I want to be fair to you, okay? If you have a question about what I use, I've been using the same stuff for 12 years. Instagram me and I'll tell you. Okay, so what you want to do regardless is you want to, now mind you, if you guys have full-on digital offices, I'm going to get to that, okay? So if you're thinking impressions, I don't take impressions. That's okay, we could do it either way. So for those of you who don't have that technology, or if you do, there are many times that I have 3 intraoral scanners, and there's sometimes it's just really easy for me to pop a PVS. So step number 1 for STL file, take a really nice impression. My recommendation, take 2. Either pour it up, have the lab pour it up, and then you could just scan the model. And what I would recommend, now that I'm saying that, is go to the 3D Diagnostix website, and there is a whole category of how to scan your patient, how to get the best results scanning a model. the voxel size, the time, the dose, all that size stuff. I don't want to get into that because we're going to run way out of time, but it's all there for you and it's really, really good. Okay, let me just move one thing over here. All right, so now, so you have choices now. If you do not have a CBCT machine, then what you can simply do is take those two really nice PVS impressions, put them in a bag, and send them overnight or 2-day them, in this case, to 3D Diagnostics. They will take over. So basically, all you'll need is a CBCT and 2 really nice impressions. You can send one. I recommend 2, because if there is a bubble in one and there's a problem with accuracy, they have a second chance. So the first way is you can take an impression, you can send that over to 3D Diagnostics and not do anything about it. The second way is you could take an impression, as you see here on your screen, you can pour up a model, have a lab pour up a model, and you could put that in your scanner and you could scan it. If I had my preference to guide you, I would tell you, go ahead and send your impressions directly to 3D Diagnostics. They have some heavy artillery to do some pretty hardcore scanning, and they will probably get more detail than you will. Next, for all of those of you who are like me, digital and have iOS scanners, iOS intraoral scanners, you can do that. You can take an intraoral scan. You would put 3D Diagnostics or a guide maker of choice into your library, and you would simply send them the file, .stl, and it's no different than sending an email to grandma or grandpa with a picture of your child playing softball. You just grab it, you send it. I'm sure you've all done that. So the first way, just to reiterate, is an impression, and you know the various ways that you can deal with an impression. The second way would be an intraoral scan, and we don't need to go too deep in that. If you have one, you know how to do it, okay? And then the third way, if you happen to do a lot of in-house milling and printing and you're very high tech, I actually have one of these 7 series scanners from Straumann. And what we can actually do is take an impression, we can put it in there, which is much like what 3D Diagnostics does. And we can actually scan the impression and get an inverse model without any stone. So those are the 3 ways. But ideally, we want to make sure that we capture the information to then get over to them. All right, so what happens next? So we have the DICOM file, which is, remember, this is for a partially edentulous patient. This is not for a fully edentulous. I'll get into that in a second. So now what we have is we've uploaded the DICOM file, as you see here. The DICOM file is anything black, white, or really white, right? So it's the X-ray. And then we've also uploaded the STL file, or we have sent them the impression and they have uploaded the STL file. That you see right here on the lower left in pink or purple, and that is the schematic setup of what the patient has right now. And then what you see above that is in here, what we're looking at is we're looking at a third-party software. So we take these files and we put them in something. And this is the job right now of 3D Diagnostics. They would be doing it from that. And from there, we could design implants and we can put them in an ideal position. Length, width, diameter. This should all be prosthetically directed. Okay, now, I want to mention something to you that I've seen on a number of occasions, and this can get you guys in trouble. When you capture this information, the impression, the CBCT, both of these dynamic static pieces of information, and you send them, and you do what you're seeing in front of you, you go through design process, nothing in that patient's mouth can change. So if you put a crown on number 30, after you've sent this information in, if you've bonded a broken number 9, whatever it may be, I want to say this more clear. In the arch that you're working on, that you plan to do guided surgery, once you upload your DICOM file, once you get your STL file, nothing on that patient can change, because this will guarantee a rocking guide. Now, when a guide rocks, do you press it down towards the site you're working on? Do you press it to the other side? Do you hold it in the middle? I can promise you that you will be 30% right. Yes, you'll be 30% right. There's 60% chance that you are wrong. Just because the guide is rocking, that doesn't mean that you should push down on the side that you're working on. And I've seen cases where implants have penetrated through the lingual plate by doing that. Holding down the guide on number 29, drilling, placing the implant in. Of course, you're going to get torque. You have bicortical stabilization. You went through the lingual cortical plate. Guides need not rock. Okay, so I'm going to talk a little bit about the pitfalls of rocking, etc. But you have to have a guide that's in place with passive pressure all the way around by you and your assistant, and nothing should rock. Squishing is okay. Okay, so now that we've spoken about the under 4 implants, now let's talk about full arch. Okay, full arch. How do we get a guide to fit that? How do we get a guide to fit on that and have a surgery that's conducive for a patient's teeth when they don't have teeth? What do we do in the second guide? Well, let's show you. Patient comes in, patient has a denture. The denture is okay, right? It's not bad. We definitely want to maybe make it more aesthetic, maybe change the positions of the teeth, change the midline. Number 11 looks like it's sticking out a little bit. Maybe give her a more feminine look, right? Not have the teeth touching the lip as they are. Yes, we can do that. But here's the point of this. For all intents and purposes, the denture's okay. And I say okay to scan her, okay. If the VDO is collapsed, if the teeth are all ground down, if half the teeth are cracked, then we are not going to use it. But if the patient comes in after X amount of years, which you're going to see right here, and says, listen, you know, it's ugly. I don't like it. I don't like anything about it. But, you know, I'm actually comfortable. I can eat. I can do everything. Okay. This is the denture that you want to scan the patient with. You do not want to put a brand new leather shoe on the foot and have them try to bite this thing down so you can get your information. You should use this. Now, I want to reiterate, if you're changing the VDO 3, 4, 5, 6 millimeters, or you are adding teeth where teeth have broken off the denture, this is not the one that you want to use, okay? But if a case comes in to me like this, I'm going to tell you, out of everything that I do, this is one of my favorite 2 cases to accomplish. Out of anything that I do, and I only do surgery, it would be this, and then it would be an all-on bone reduction type surgery, which I'll show you at the end. And the reason that this is my favorite, I'm going to tell you, is because the teeth are already out, the patient's already in a denture, so that all of that morbidity, all of that pain and blood and extraction, just headaches for everybody are behind us. So guys, I want to encourage you, if you have a patient that walks in like this, this is a needle in a haystack. And if you've got these, you want to work with these. Okay, so what do we do at this point? Well, there's 2 things that are imperative, absolutely imperative that you do. I want to remind you, the way that this denture fits this person's mouth is the exact same way that the guide is. So when you see a denture like this, in your mind's eye, I want you to look at it and say, that's the guide, because that's exactly what it's going to look like minus the teeth. So what do we need to do? Okay, number 1, we have to have ideal prosthetics. And I know that I just kind of contradicted what I'm saying, but I think you understand. If you're close, and I would call this close, okay, yes, I might close her a little bit, depending on what she wanted to do on the bottom, etc. But we are close. She's not complaining about any other thing than pounds of glue and having to take it in and out. And she wants dental implants. Okay, so 1 is the prosthetics. If it's way off, then go through the process of making a new denture, even if it's a wax up. The second thing, which is majorly important, is you have to make sure that the intaglio surface of the denture fits like a glove. It has to touch that pink tissue everywhere. So let's show you a very quick and inexpensive way to do that. Radiolucent reline, okay? There are a lot of reline materials that you can use for this. You've got to make sure in this protocol, okay, and this is just one way, other people do it other ways. I will tell you that 60 to 70% of my surgeries are full arch. I've been using this stuff for the last 12 years and I do okay with it. So I'm just saying that this works. It's not the only way, but this works. So we want to take a radiolucent material. We want to put it in the patient's mouth. We want to massage the top lips down, overload this thing, okay? Massage the top down, massage the lower lip up to create a really nice periphery as you see it here. On the lower area of the screen, you see that there's flash. With the material I use, we don't remove flash until we've bathed it in some water at 120 degrees. then we'll remove this. Now we have a denture that is ideal fitting to the tissue, the intaglio surface. And what this means is our guide will too, okay? Now, this is where we differentiate between a person with teeth and one that doesn't have teeth. And this is pretty much where guided surgery all started. Now, we've made movement in this direction as well. So if you've heard about duplicate barium sulfate dentures or gutta-percha balls or all of these things, we have done all that. I have done all that. We have moved to something that is very minimally invasive. We don't have to put any holes in a denture. We don't have to spend the money duplicating a denture at $250 or whatever it is, or if we do it in our office, the time. So what I'm going to show you is something that has been used in a lot of different entities of life, okay? And it's called motion capturing. And the way that we're going to do this is we are going to have 2 points that aren't connected, and we're going to connect them. And I'm going to show you an example. So what we're going to do is we are going to use what's called a glass bead. Now, again, there's many ways to do this. This is the way that I do it. It's very inexpensive. These beads that you're looking at are like 50 or 75 cents a piece, okay? Soft reline, nothing. So what I'll do is I'll soft reline. Then what we're going to do is we're going to put these beads on, and I'm going to show you why. When you put these beads on, you want to stagger them. You want 3 on the palatal or lingual, and you want 3 on the facial. And when I say stagger them, just imagine if you were to take an x-ray and it would give you essentially a slice in a pano view. We just don't want those beads to touch. If they do, it's not the end of the world, but we would prefer that one's over here, one over here, one over here, one over here, kind of like you're tightening the nuts and bolts on a wheel, on a car. Okay, now there's a couple different ways to do this, but I'm going to tell you my way. This is going to serve as the patient's teeth. Now, many people teach it differently. I'm going to teach it in a way that works, and I'm going to explain why that I think it works best for me. We're going to do a dual scan. So we're going to treat this just like a patient with teeth. We are going to scan the patient, and then we're going to scan the arch. So we're going to scan the patient wearing this. But before you do this, I want you to take scan 2 first. I want you to take the STL first. And what that means is a scan of the model. And in this case, this is the model. So we are going to do a dual scan technique, but we're going to start with the second one. We're going to scan this first. So you would take this and either use an intraoral scanner. There's a lot of great scanners out there that can do this. Pardon me. Or you could put this in your CBCT. Now you want to do this 1 arch at a time. Excuse me. The reason I'm telling you that I want you to do the second one before the first one, I'm going to try to get through this, sorry, is because when you put this in the patient's mouth, these beads can get moist. And if they get moist and they slightly move, it will not match your second scan. So do the dry scan first. This being the dry scan, the scan of just the dentures, okay? So question is, what if you are doing upper and lower? You can scan the patient wearing both of these prostheses when you scan them with their teeth. And then when you're scanning them alone, that is 2 separate scans. That is 1 for each arch, okay? Much like a regular patient. So the dry scan first, then we're going to scan it with the patient wearing them. Now, as I mentioned earlier about motion capturing, many of you have seen Ants' Life, Bugs' Life, all these different movies where humans look like animals, or animals have expressions of humans, and you may wonder, how is this done? Well, very clever people taking 2 things and merging them and making an ant and a person look like the same thing. So that's essentially what motion capturing is, but you have to use something called a fiducial marker. So if you look here, this started in movies well long ago, and now it's in medicine and dentistry. If you see here, these little glass beads, these are fiducial markers, and they did the same thing that I'm explaining on how to do the denture. They place these fiducial markers on people in a green room. They create movements, and then they can superimpose those markers on anything they want. Like you could see the Ninja Turtles, or if you have seen, I'll show you a cool little commercial. Interestingly enough, I started putting the slide that you're seeing in front of me, in front of you in my class about 3 years ago. And I could have picked anything, and there was a very interesting end to this. But anyway, I'll show you right now. I did this about 3 or 4 years ago. So you take a man and you take a mango and you make a man go. And that's pretty kind of funny. I didn't do a great job at it because I don't work for Pixar, but nevertheless, this is how you do it. Oddly enough, very oddly enough, 3 years later, this came out.
This tastes just like I imagined Phil would taste.
Phil in a bottle right here.
It's uncanny. Whatever happened to Phil?
Mangoes are great. Snapple mango tea tastes just like them.
Cute little commercial with a mango and a man. That was pretty interesting. So I was kind of shocked when I saw that myself. It was a matter of chance. But you could see how in that video, and I'm sure some of you have seen that, they made these mangoes look like people, like men or female. I would say male because they had male voices, but other than that, why not have a female mango, and we'll call it a womango, right? Anyway, avatar, all of these things that I'm showing you, you have seen. Okay, so let's take this back to dentistry and let's talk about how this works. What you're looking at now is the patient wearing the denture inside the scan, much like if a patient took a scan with teeth. They go in there with their teeth, right? So we are going to put this patient, in the dentulous patient, in the scan with their teeth. And what you'll see here is this is an outline of the bone. This is the outline of the denture or the incisal edge of the tooth. Now I can very, very accurately position my implant to be in the long axis of the tooth or the cingulum. And this is fantastic because I would say in 95+% of my cases, nothing comes through the facial. Even more, probably 98%. On my dentures, implant over dentures, they all land in the deepest part of the vestibule, so I don't have any show-throughs of abutments. And you can plan it simply by this. Now, I'm gonna go back again. What do you notice about this, or what do you not notice about this? I'm going to show you something. If this is the bone, and I'm hoping you can see my cursor, this is the bone, and this is the outside of the denture and the denture tooth, okay? Where's the separation? Where is the separation? That's the whole point, there isn't one. So I'm going to show you how to look at separation. It's very, very easy to do. But when you can have bone go into a lucent liner, which with the technology that 3D Diagnostics has, they could decipher whether it's lucent liner or gum tissue, blended into the denture like this, you know you have a good fit. Again, the bone, the outline of the tooth, the position of the implant, and put it in, okay? And we'll get more on that as well. Here is, I apologize, it kind of went backwards a little bit, but here is what I do with the denture scan. This should be your first scan, okay, not your second scan. We want to put this on something that is radiolucent, thus the cotton rolls. The reason being is that if you put that on the bite tray or the chin tray or anything like that, that has metallic in it. So what happens if you set the denture on the metallic tray, that white tray that you see, or the chin rest, what'll happen is they will not be able to see the edges of the teeth clearly. So when they see this scan, they see the teeth up here and they see the bottom of the CT down here, and that's it. So they can clearly decipher where the edges of the teeth are. And the reason that that's really important is because they merged the two scans together, you've guessed it, by the edges of the teeth. Okay, really quickly, the sugar mark beads, we want to use 1mm beads. 3D Diagnostics does not make sure mark beads, but they distribute them. You get a roll of 50 for about 70 or 80 bucks. Okay, guys? So this is really easy. You just peel them off. This was just a quick reline here just to get the patient scanned. This was actually a wax up, so the patient was not going home with the denture, thus the edges not being completely clean. Now you can scan a patient in a wax up. You don't have to go to a complete denture. Essentially what we're looking for is we're looking for the base rim. That's pretty much it. As long as the teeth are secured in the rim, we're good with that. Doesn't have to be a fully processed denture. Okay, what is not a good denture? It is this that you're looking at. And if you look here, you can see a clear issue with the patient in the CBCT and the actual bite that's created. So you see a lot of dark space on the patient's left side, as you see here. On your right side of the screen it would be, but the patient's left side. You can also see on the patient's right side, your left side, that it looks like almost like the denture is hitting the bone. So the way that when I said it's really easy to determine if you have space or not, the way that we do it is we want to go in and out of the coronal view, in and out of the patient's face, into the patient's face, all the way through the denture, come back forward, go back through it, do it 2 or 3 times. And if I see any space like this, we are going to rescan. Now, 2 things. One, I've trained my assistants. We do quite a bit of this, so my assistants can catch it as yours can. It's very easy to do. Just spend time with them and just show them how to scroll forward and backward in the coronal view, and you will be able to catch this. There are a lot of great tips on how to take a really clean scan, such as this. Well, this isn't clean, but I think you know what I mean, on the 3DDX website. Again, there's a library of stuff. It's imperative that we know how to keep soft tissue away from the skull. It's also imperative that we keep the tongue away from the teeth. There's a lot of things that we can do that can really help our scan. The other thing I want to mention is don't have your patient bite on any bite sticks in any CT. If you do, they do not have proprioception in the denture will lift. So my recommendation is 6 cotton rolls. We are going to place 2 on the outside. Actually, we're going to place 4 on the top, and we're going to place 6 on the bottom. So we're going to place 2 in the vestibule, cotton rolls on the top, and we're going to place 1 on each side between the bicuspids and the molars, have them gently bite down, and they feel it until they feel it close. We are not pressing. For the lower, we are going to use 6. We are going to use 2 on the buccal to push the tissue out, the lips away from the face. We're going to have the patient lift the tongue. We're going to put 2 under the tongue to keep the soft tissue away from the teeth. And then we're going to use 2 more for them to bite on between the bicuspids and the molars. And if you can move the soft tissue away, it makes the merging much more clear and easy. It makes the whole surgery that much more clear. Now remember this, okay? Read this to yourself, okay? The surgical guide will mimic the scanned appliance. So if you're scanning your own stuff and you're milling your own guides or printing your own guides and you don't catch this, God help you if this is your surgery. Now, that being said, I just want to kind of compartmentalize a couple things here. There's a lot of us that have technology. There's a lot of us that have the desire to be technological, and there's some in between. So I'm going to tell you that 80% of us are actually taking these 2 scans or 3 scans in the case of upper lower dentures, and we're sending it to 3D Diagnostics. And then what we're going to do is join a webinar with them, look at the procedure, look at the surgery, design the surgery, and then we're done. That's it. So we borrow them and their knowledge for the software, for the session. They're going to move things around, and then they're going to print my guide. 80% of us do that. 15% or so of us will actually, which I do not do because time is my commodity. About 15% of us will actually go and purchase some type of software. This software that you're going to be looking at today, Diagnostix, has actually done the most guided implant surgery designs ever since the inception of this. So it's quite a great software. And then, so it would be about 15% of us would design our own cases and then send the file off to 3D Diagnostic. And for less money, they'll print a guide for you. And then there's 4 to 6% of us that do it all. And if you are doing it all, that's great. If this is your first or second or third surgery, I highly recommend that you rethink that. Okay, so we have it here, okay? So it's quiz time. You guys ready? All right. Number 1, what file is the green picture? Number 2, what file is the purple picture? If you said file number 1 was DICOM and file number 2 was STL, you're right, you got it. Now, in a case like this, I don't want to get too much into partially edentulous cases because it gets a little confusing. Suffice it to say that you're going to treat a case like this, a partially edentulous case, just like you would fully dentate. So you're going to take a really nice clean STL because the guide proximity to 2 teeth is very tough. So you're going to take a really good STL file, excuse me, and that's what your guide will be made from. Okay, so let's talk about some nomenclature and go through the actual designing of the guide. So you've sent them everything, you know how to do your scans now. Let's move. Okay, case planning. So this is where you take the 2 files, you're going to go on a webinar or go to meeting with them, and they get pretty quick after a while. They input your defaults. So do you like this? Do you like that? Do you place your implants subcrestal? Do you like them at the crest, etc.? So the planning will typically get easier and easier and easier and easier, and you will have your own agent, so to speak, at the other end that will help you, and they will understand your needs pretty well. Now, to my understanding, and one of the reasons that I have used 3D Diagnostics, to my understanding, they are the only company that I know of that has all doctors planning these guides for you. That's something that I'm not sure of, but it is to my understanding. What I do understand is they are all doctors, and they're incredibly knowledgeable, and they can help you with a lot of things, including things like anatomical learns, etc. So, okay. So let me show you a case that went really south for me. Yep, it's me, Dr. Engel. 2,000 plus cases, whatever, I don't know. And something so easy went south. Now I want to mention that 3D Diagnostics was not a part of this case. It was another guide manufacturer. It wasn't me. And thus the reason that I leaped over. I've been with 3D Diagnostics 4 years now, and I've had not one catastrophic event. Let's look at this case right here. Teeth number 10 and 11 missing. Now there's a couple things that I want you to understand. Implants should go under teeth, period. Implant shouldn't be in between where teeth should be. The only time that positioning of implants could wax and wane a little bit is if you're certain that you're going to an overdenture and the patient's never going to change their mind. Because there is nothing good about having an implant in between two teeth, period. So in this case, a patient comes to me, she's missing 9 and 10 for a long time, and everything shifted forward. And I've got pretty good room for implants, but if you notice, the contact to contact is very small. So an average lateral incisor mesial distal is about 7 millimeters. The average canine is probably 7, 8, 9 millimeters, depending on the size of the person. So we could need anywhere from 13 on the small end of millimeters all the way to about 17 millimeters of space, 15 millimeters of space for teeth, because I think teeth first. My problem is I had just a little over 11. So I talked to the patient and I said, listen, this is not ideal. We're gonna have one small tooth. We have to figure out which one we want. And then depending on what she decided, we'd make those teeth. I knew I was going to cantilever. My personal recommendation, this is just me and the way that I do things, the only way that you're going to figure out any failures is by keeping things consistent. If you've ever been to Vegas and you've played blackjack, you either stay on 16 or you hit on 16, but whatever you do, you should keep it consistent, because now what you're trying to do is you're trying to guess your way through it. So play your odds. So in this case, I have about 11 or 12 millimeters, not even 12. So I designed the teeth. So what we decided on together, we had 11 millimeters, was that we were going to make a 6 millimeter canine and a 5 millimeter lateral incisor. Not very aesthetic, but there's a reason to this. I had to figure out where I was going to put my implant. I don't know if I finished my thought. That is, I always personally cantilever mesial, okay? And I want, we can go to the physics later, but I cantilever mesial, and we'll get into that. But so I decided that I was going to put the implant under the canine. Well, how does this play in right here? Well, if it's under the canine and the canine is 7 millimeters wide, then it has to be exactly 3 millimeters off the contact, or 3.5 millimeters off the contact of that bicuspid you're looking at. If I scoot 5 millimeters over or 4.5 millimeters over, then I've kind of put an implant in a position that's not underneath the tooth, right? It's in the middle of two teeth. So my implant has to be exactly under this tooth. So what you're looking at right there is the exact position that my implant had to go to essentially have a canine that looked really, really good, and then a lateral incisor that was cantilevered that looked really good, except it was a peg, so to speak. Okay, let's look. So here was my plan. So what you see here, the blue is the outline of the tissue. The bone is obviously the DCM gray, white, black image. And we uploaded again. I wanted to make sure that I say this again. This was not 3D Diagnostics, and I feel it's really fair to say that because obviously they're putting it on. So my design was with this particular company, one implant, and we were going to put it in this spot. The bone, it all around was very questionable, as you could see by the image on the left, or on your right, rather, the axial view. So I really had one spot to put it. And this is what I'm talking about. Could I have freehanded it? Of course I could. I've done 15,000 flaps. That's not the issue. The issue here is that it needed to be exactly in one spot. And if I could prosthetically put it in where I want and then put this thing right underneath the butt of the tooth, I'm good. So this was the spot we chose. Well, let's show you what happened to Dr. Engel on his 896 case. That's me. Yep. Oh, whatever. Fill in the blank. So I'm not too proud to show you. I have the knowledge. I've done a ton of these. This is my case. This is my case. 2/3 of the implant on the palatal is completely out of the palatal wall. So I have never seen anything like this before in my hands, and I just was at an awe. So I figured, okay, well, let's go and let's look at how this could have happened. Called the patient first. I said, hey, listen, I just want to let you know the implant is not in the position that I would like it to be in. I need you to come back, and I'm going to need to remove it and replace it. And I apologize for this, but I want it where I need it. She fully understood, and I think a lot of it is in the articulation of what you say to your patient. Different game show. We could talk about that. By the way, I'd love to see one of my classes. They're pretty cool. So let's look at the two files. Now, the one thing that I wanted to tell you is the guide fit like OJ's glove. Okay, I mean, it fit perfect. So let's rule this out. If a guide fits perfect, especially on a tooth-borne guide with all these teeth, if the guide fits perfect, what are you thinking in your mind was good? What is it? You should be thinking that either your scan or your impression, because your scan is just like a night guard. If your night guard doesn't rock, you gave someone a good impression to make a night guard. So my impression was good. What's the other part of it? Well, the other scan is the DICOM file. What we know is that CBCTs can fall in and out of calibration. Footnote, check your CT, call the company that you work with, and make sure that you're on top of when it should be calibrated. Is it once a month? Is it once every 90 days? I don't know, but you need to make sure you're calibrated. So I had my team come in and make sure, when I say my team, the CBCT company, come in and look at the calibration. They said it was spot on. And they showed me the data about how they do it. And they do it with little tiny spherical beads. It was dead on. So what could it have been? I want you to think about this. And I'm not going to give you a whole lot of time because we want to move on with the lecture, but think about this. So the scan was good. The impression was good. The guide fit good. What is it? Well, at some point, a knowledgeable, competent, and trustworthy human must get involved. The error came in the merging. So at some point, you need scan A and scan B to be merged together impeccably, in order for you to have the confidence that your implant's going to go where you want it to go, regardless of how good the damn guide fits. Trust that. I'm telling you, I just showed you. So in comes 3D Diagnostics for me. I've been teaching implant courses for 18 years. I do all kinds of guided courses, from single guided to bone reduction, immediate load courses. I have an open access to who I would choose to work with, and I have chosen 3D Diagnostics for that reason. It's not a reason of money. It's not a reason of notoriety, because that's not going to save my cases. It's product and people and customer service. So I want to give you a big kudos, 3D Diagnostics, on that. So thank you. Okay, so let's look now at how does this work now. So basically what you're going to do is you're going to go to a website. This is a 3D Diagnostics webinar, so we would go to their website. And what we're going to do is we're going to click on fully guided cases, and I'm going to walk through, okay? Here is Mr. John Smith, and what implants do we plan on placing? And are we doing any extractions? This is really, really important. Remember, they want to know what's going to be happening at time of surgery. If number 5 is in the mouth, but you plan on extracting 5, you need to tell them, okay? Et cetera, et cetera. So you just walk through the list, and then what implant are you using? In my particular case, I'm a Straumann user. I'm doing a hybrid here. I'm doing a little bit of a sinus lift. And that might be extravagant for you. And if there wasn't any other augmented procedures, then you just put nothing. Anyway, you're going to go down a couple of pages, fill out the information. Then you're going to hit this check mark that says, I agree. And what you're agreeing to is that the liability is on you. They have nothing to do with the surgery. They are just trying to help you make a guide for the surgery. Okay. This right here is a really important part. This is when a specific time when you're going to do your fine-tuning session. This is your go-to meeting. So you suggest a time and a date, and they will get back to you by email. And then you're going to have other options as well, like, do you want TMJ evaluation? Some of you may want a radiographic interpretation or a pathology interpretation if you see something that's odd, but you don't know what it is. Okay, and then you'll ultimately get your menu of items, and you'll get a fee, etc., whatever you choose. Now, the next thing that we're going to do is we're going to choose a file. So just like you are emailing a picture, I'm going to go to my desktop. I'm going to find Lisa R's DICOM file, and I'm going to hit choose. And then what I'm going to do is, if I have an intraoral scan, I would go to choose again. I'd hit the intraoral scan, and I'd upload that, and those would be my two files. In my case, I'm 50-50. Sometimes it'll be a scan. Sometimes I'll just check the thing that says, I'm going to send a model. Okay, and then you're going to hit the submit order. Now, what I'm going to do is I'm going to go to a share screen, and I'm going to go here for a second. Let's see if I can. All right, so hopefully you all can see this. Let's go through this. Let's walk through the live interactive. Wow, look at who's that. So what you're going to do is you're going to come up here, you're going to click, okay, and then you're going to get this screen. I'm sorry for my delayed. Now, this is going to be your personal login. You'll have your library of all of the cases that you are currently doing. So you can scroll down, and these are all of my cases, see more cases, etc. Okay, so you could go back years. So these are all of my cases that I've done most recently as of when we were working. So you could find where you are anywhere on anybody, or you can upload more. Now, anything in red is basically saying, hey, I need something from you. I need you to call us. We have a model that we can't work with. Anything in green says it's in process. Anything in yellow is just information that they want to be passing forward to you. So in our case, if we're doing a fully guided case, we would click on here. It would take us to this site, and we could put just Mr. X. And so we're going to do number 5, and that's it. And that's all, just one implant today. And it's weird. You want to do it guided because maybe the roots of 4 and 6 are really tipped. Maybe you're really nervous about apically drilling, but they have number 5. So let's do an immediate. How's that? So we'll do an immediate, and we'll press that we have 5. We're going to take it out, but let's also place 5. And then what they'll do is they'll superimpose your design over the implant root, and they can see all that. They have incredible technology that can really show them what they need. And then we'll just walk through the rest of the steps, okay? So I'm going to go back to my lecture here. So that's kind of like a, let's see here. Okay, let's share. Sorry, guys. All right, so here we are. Hopefully, are we back to the lecture? I hope so. Okay, so now let's talk about design, okay? And this is really, really important here, okay? There are a few variations. I mean, you could be placing any number of implants. You could be using any type of drill kits, et cetera. So I'm gonna give you the basics that would be pertinent for anything. And I'm also gonna skip over some of the stuff that is like guide surgical kit conducive. Or like if you use BioHorizons and you have their kit, I can't really go into every kit and every key or keyless system, but I'll show you where it kind of all comes together. So you're going to get something that kind of looks like what you're looking at, and that's going to show you the position in the green box. It's going to show you the sleeve, and we're going to talk about the sleeve, okay? Here you see 5/0 sleeve. and I'm going to explain the difference between a couple different types of sleeves. Then you have implant related information. So whatever implant you're placing, you'd have information there. For me, I have a 10 millimeter implant going in. It's a Straumann implant, 10 millimeter implant, and that's conducive for what I do. Okay, and then lastly, the surgical protocol. And again, this is going to change. Dots, diamonds, lines, whatever you have in your drill kit, you will get a recipe there. So if your recipe is Heinz 57 and you use Heinz 57, that's really something that is your choice, but it will be located in that fuchsia colored box, okay? The one thing that I want to take note of here, though, is the H4, and H4 is height. Now, you may not have that exact description in a kit that you may be using for Straumann. It's described as H4. And H4 means H height for 4 millimeters off the platform of the implant. And I'm going to show you why that's important. Okay, that's going to be directly related to flap or flapless. Then it's going to go into a drilling protocol and a handle protocol if you have a handle or a drill, etc. Okay, so let's continue. Ultimately, what you're going to get is you're going to get a surgical protocol, like you see here. Mine's for Straumann, of course. And what it's going to do is it's going to walk you down your protocol. So whether you have dots, lines, diamonds, whatever you have that's conducive for your kits, it will be listed here. But it is a step-by-step process. Now, just because it's giving you all these steps, that doesn't mean that you have to do them. For instance, this red drill right here. This is the drill for a specific implant. If I feel that the bone is soft, I would stop at the yellow drill. This is all predicated on the surgeon understanding what he or she is drilling. Okay, all right. And then the surgical guide will be made accordingly, H's or letters or not diamonds or whatever your system has. Okay, let's go into the different types of guides now and why we do different types of guides. Okay, two supported guide, tissue supported guide, bone supported guide. Let's just hit on that real quick. Okay. Two supported guide, as we said, it kind of matches the kind of like the general rule of the CBCG. If you're missing 4 or less teeth, we're going to consider that a two supported guide. And you could have a combo tooth tissue supported guide, but two supported guide is one that rests on teeth. It's without question the most secure one, the most comfortable one to use. So for you who are beginning first time, second time, fourth time, I highly recommend that maybe you choose these as some of your cases. So you can focus on the protocols of surgery rather than is the guide rocking on tissue. I think it's really good to learn in increments. Now what you see here is you see a big hole and a little hole. You see a guide, a pilot guide. You also see a fully guided, a pilot sleeve and a fully guided sleeve. And we're going to talk about that in a minute. The next thing is a tissue supported guide. Tissue supported guide would be, in a case like this, you see an edentulous patient, so it's considered a tissue supported guide. How do we hold in tissue supported guides? Well, those are held in with anchor pins. Now, anchor pins are also done in the design. They are done by the coordinator with you, so it's no different than planning an implant. It's just shorter and it's planned horizontally into the jaw, away from everything else, nice and safe. Okay, now, these pins are a certain depth and a certain diameter, and it's imperative that you understand that when you're designing. So if you design a case and you set anchor pins, you have to have those anchor pins that is on the design. So I'm just going to give it to you short. These are 3D diagnostic anchor pins. This is a 3D diagnostic drill. Everything is measured for that. So I don't have to worry about buying off brands or stopping short or not being long enough, etc. This is about 1.5 millimeter drill. It's about 17 millimeters long, and it's identical to the part of the anchor pin that sticks in the jaw. Now, here we go. We're going to go gently up and down. I usually use 2 hands, but I needed to be clear of the video. And the reason that I'm saying gently with 2 hands is because these drills are very, very fragile. You will break one. There's no question you will break one. My recommendation is have it at least 2. I think that's a low number. I would have 3 of these drills. They're not very expensive. If you drill a hole and you break your drill, you have no way of securing this in safely with anchor pins. It's a very, very inexpensive way to save a lot of trouble. Okay? And here is the anchor pin. You'll see this one is already in the center. We're going to put them in. We're going to stagger them side to side like you would tighten a tire on a car. You don't want to go from one end to the next.
There you
Just
go.
push them into place.
You will.
Just like that. Now, it is really important that you have passive pressure on both sides with you and your assistant, and they are gently pushed in. They are not meant to be hammered in. You don't force them in. This has to be a passive fit. Now, this is the last one, a little extravagant. This is a bone guide, and it can be done a number of ways. Like, this is a very common procedure in my practice. We're going to put on a bone reduction guide. This requires a very large flap, followed by the bone reduction itself. And then on top of that, we would stack an implant guide. Now, there are bone-supported guides that you just open the tissue and you put the bone guide right down on top of the bone, like you see on the schematic on the left, without bone reduction. So you could do it either way. Okay, so you have a pilot and you have a 5.0. Now, the reason I'm saying this is because when you use a pilot guide, if you have a handle system, if you don't have a handle system, that's fine, or a keyless system, etc. This is one and done. And this is to get your pilot drill in to give you the path of insertion for an implant, and then it's done. Everything else is fully guided, okay? So the 5.0 in my case, and these are gonna range from 4 to 5 to 6 millimeters depending on your kit. So if you look here, I have a pilot guide sleeve. I take my pilot drill and I drill to the hub, and then I'm done. That's it. That's a pilot sleeve, and this is done for accuracy, but this also means that you're going to have freehand placement. Now, the deflection of bone, hard or soft, can push your implant in a direction that's not exactly where you want it. So try the best that you can to allow the implant to follow the path that the drill went into if you're removing the guide to do that. Let's look at a case. Here's ChemFit. We're doing number 19. Why did I choose to do this guided? Well, there's a good kind of a PA version of a pano. And if you look here, I have 6.5 millimeters of prosthetic space. Now you might be saying to yourself, well, smooth the filling, give yourself more space, yada, yada. And I would agree with you. There's no question. But I do get a lot of referrals, and I don't always have that option. And I kind of refrain from telling dentists what they should do. If they come to me for an implant, I give them an implant. In this case, I think that they could figure out that they should polish. Nevertheless, the problem here is that if I have a 5 millimeter sleeve plus all the acrylic to make the sleeve stable, it won't fit in there. So let's look at this case. So the one reason that I would use a pilot sleeve would be for proximal spacing, that I didn't have enough. Now, if you look here, axial, sagittal, coronal, okay? This is the axial, this is the sagittal, and obviously here is the plan. So let's look. Here's the axial. So what you're looking at is head to toe view. This is at the top of the implant platform. So when we look at the bone on the lingual and we look at the bone on the facial, it looks pretty good. We have 2+ millimeters. In the sagittal position, it looks really good. We are in bone. We don't have to worry about the buccal defect. We can bury it slightly below the crest and still be in the appropriate prosthetic position. So far this is looking good. Now, can I do this freehand? Of course I can. You make a little flap, you move the tissue out of the way, and you drill. But there's probably a good probability that it wouldn't be right under the tooth like this one is, right? So we go ahead and we have our STL file here, and we have our guide here. Now, what you're going to notice is there's windows, and 3D Diagnostics tries to give you 3. That's the key to knowing that the guide is down. You want to make sure that the tooth is touching the guide in the window. If it's not, and it's rocking, I'm going to tell you a really easy way to do this. Take articulating paper, put it in the guide, seat the guide down firmly on the teeth, rock it a little bit, take the guide out, and it will mark exactly where it's high. Take your drill really cautiously and just roughen up that and remove that high spot on the guide and reseat it. You don't want to remove tooth structure, okay? All right, and so here we are. We have a tripod. We have kind of like a PMMA or an acrylic arch that they're going to send with you, to you with the guide. And here's the pilot sleeve. So let's look. So now, what I did was I flapped this, and this is irrelevant to the type of sleeve you have. The reason I flap this, we go over this in the classes, is because they had mucosa. They didn't have enough keratinization, and so I didn't want to drill through mucosa. Okay, so we go in, we go ultimately, when I go between teeth, I always pop through and penetrate the cortical plate. I'll take an x-ray. This is really important just to make sure that you're diving straight. Then I'm going to go to full depth and we're good. I'm going to take my 2.9 millimeter, in this case, active implant, and I'm going to go and I'm going to place it, just like you see here. Nice placement. I buried it a couple tenths below. That's my cover screw, and I sutured it shut. And the reason that I did the flap like this is because had I got really good stability, in this case we had about 25, and I just felt like I wanted to bury it. Okay, and suture it shut. So you can see, anytime you have a buccal defect, you are going to have some type of a keratinization issue, and we talk a lot about that in the class. So looky here, wonderful. Very, very happy with this. I probably could not have done this freehand, especially since there's a slope here. I probably would have leaned. I would have fell in this direction, maybe a little bit too lingual because I was concerned about the buccal. But if you look here, this is the platform of the implant. It's exactly where the design was. And if you look here, ideal. We planned it underneath the tooth, and the tooth is going right towards the palatal cusp of the opposing molar. Perfect. This is a really, really good day. The stress level is very, very low, okay? There's a lot of things that go into this. Good scan, good impression, non-rocking guide, and, you know, take a shot of whiskey and relax. There you go. I'm very happy with this. Very clean. And there he is 30 days later. All is well. Okay, let's look at this case. Another reason why we would do a pilot stent. And again, thank you guys for your time. I'm trying to go as quickly as I can, but I want to give you a really good learn. We've got a couple cool cases coming up. So this is just to help you decipher what and where. So with these types of cases, with the case that you're looking at here, you know, an edentulous maxilla, typically atrophic, right? They get thin and short really quick on us. That's a different game show. But anyway, what I typically do in these cases is I get a really nice fitting guide. I get pilot sleeves. And then what I'll just do is I'll go in with my pilot drill. I'll do my pilot drill, I'll tissue punch, and I'll place my implants. Why do I do that? I do that to allow the implant to actually move the bone out of the way. So the implant is doing like an osteodensification where it's actually moving the soft tissue out of the way. So I always say, push it like an accordion versus drill it out. So we're actually compressing this type 3 or 4 bone into type 3 or 2 bone, which is really, really conducive for the implant's survival, or help anyway. Now, so those are a couple of reasons that I would do a pilot sleeve, okay? Now let's look at a fully guided sleeve. And for me, it's a 5.0. So insert number, whatever, if you're using a different implant company. One of the reasons I like what I like is because my drill is made for my implant and my drill is made for my handle, and all the depths are accurate. So it's fully guided. There's no guesswork. Okay, so this is a 5.0 sleeve. And what does this mean? This means that if you have handles, the handles are going to go in. If you don't have handles, that's fine. Then your drill will fit right into the sleeve. But nevertheless, everything would be guided. Now, if you look at this case, it doesn't mean that we have to do everything in order. So let's look at this. I have a thin ridge here, pretty good tissue, but I have a very thin ridge. You can see how it's tapering at the top. So how would this work out freehand? Well, I'm not thrilled about any of it. So this is a good guided case. So in this case, we have a narrow ridge. We're going to go fully guided, but we're going to do this one a little bit different. So let's look. So now here I have plenty of prosthetic space. So you could see I have my 5 millimeter sleeve right here. I have plenty of acrylic. This is really important to have thickness of acrylic. Otherwise, when you push, the whole guide will break. You have to have this embedded in minimum of 1 millimeter of acrylic. The prosthetic space should be no closer than 7 millimeters. Okay, that's for sleeve fit. Okay, so I have enough room. So let's look at this case. So I mark the spot, I punch the spot, and I place my guide. I drill with one drill, and I place my implant. Okay, there we go. Nice, like it, good. Now, don't ever worry yourself when you see x-rays such as this or such as this, and you say, oh my gosh, I'm too far subcrestal. You're not. The palatal bone is always, in this case, lower than the facial bone. So the facial bone is somewhere right around here, about a couple tenths of a millimeter. So just for all of you individuals who may be new at this, do not worry about this. Again, if you do a tangent x-ray, meaning you make a T, right? Here's the source, here's the cone. you're going to get something that's going to look like this with the superimposition of bone from the palatal, but don't worry yourself. Okay, so in this case, what did I do? I used a fully guided sleeve. Why? Because I wanted my implant to be fully guided. I wanted to put the implant in fully guided because I felt the bone was really soft and maybe it would have taken a different path of insertion on me. So I went with the handle and one drill, and then I aborted the drilling and I went to guided placement. So that's what I did here. Okay, let's look at another case. Let's look at a multiple like here. So here we have a case of a patient wearing a partial denture forever. We send a really nice PVS impression, which you could see in the gray right here. And then the guide would actually be manufactured off that. And then the design obviously would be also within the CBCT DICOM file, the merge. Well, let's look. So there's a couple tips here, and I just put these in this morning, okay? Because I want to make sure that I tell you. I want you to watch, I'm going to play this twice. It's very short. Just watch the video. Don't worry about the text on the right. It'll make more sense in a second. So I'm drilling. Okay, now watch my drill. Watch my handle. Okay, now I want to point out the tips, and I'm going to show it to you again. Tips: when you remove the handle, use the drill tip to hold down the guide or your finger. And I also want you to notice when I play it again, you're going to see a black glove over here on the patient's left side holding it down. If you do not secure the guide and you rock the sleeve out or you rock the drill out, you will rock the guide, and these anchor pins will essentially move back and forth, and you'll open up the hole and this guide will be loose. So I use the drill tip. I remove the guide by swiveling it around the long axis. I didn't go up and down with the guide. Swivel it and slide it out. Stabilization of the guide, dual stabilization. Let's watch it together. So there goes my assistant's hand. You'll see the assistant's hand go in. Gentle pressure. I'm gently holding the handle in place. I'm going in with my drill, pumping irrigation, coming out, holding the guide down, swiveling the sleeve on the handle on the log axis. Very important. Do not swivel the guide front to back. You will loosen your guide. And here we are post-surgery. Now let me tell you, what we have here is, like, I don't know, it's about a 5 or 6 unit bridge here. We're going to ultimately replace these two as well, but we wanted to do it all at one time. But if you look here, I have a bicuspid, I have canine, I have a cantilevered lateral, I have a central, maybe the other central, whatever. These are all under the teeth right as the bridge is designed really aesthetically. So this is exactly after the surgery. Punch case, no flap, no incision, no sutures. This case for me in my office is no more than 20, 25 minutes. For you guys, add an extra 10 at the beginning if you're new at it. But this is easier than a 2-surface composite for the person who knows how to execute this procedure, including you guys. If I'm having surgery, I want it done this way. Again, I'm going to emphasize that we are going to fix crown and bridge. I have an associate who does that all at once. So we've left those right now. So this is immediately after surgery. You have no bleeding. This is our immediate provisional, and this is the provisional in the patient's mouth 60 minutes after surgery. Okay, is it gorgeous? No. What about the midline? Well, it's right underneath the papilla, so we could figure out all that later. But I mean, this lady, an hour and 10 minutes ago, didn't have any teeth. So what we'll do is we will then later go back and we'll fix this tooth over here, we'll fix this canine over here, and we'll beautify her. Here's the provisional in place. Now let's look at a full. Same thing, we're going to scan the patient wearing the denture with the beads. We're going to scan the beads on the denture by themselves. And voila, we go to a 6 implant hybrid, perfectly positioned to support this hybrid, all in keratinization, punches, etc. This is 3.5 weeks later. I mean, this is amazing. And then her temporary interim prosthesis. Beautiful. Now, here's the key. Here's your take home. Have ideal prosthetics resolve prior, say it to yourself, to any implant placement. If it's a couple consultations, that's fine. You do not want to do any surgery until you know where the teeth are going to be. Okay? All right. Again, thank you guys. I don't know how far I am into this. If someone wants to shoot me or send me a text, it's cool. Okay. We're getting to the end, huh?
Hour 25.
Hour and 25. Hour and 25. Okay, I'll be done here really quick. Thank you all. Everybody stayed except 4 people. Okay. Okay, surgical execution. I have a message from 3D Diagnostics. Let me read it. I know I'm good. I'm just kidding. Thank you. Thank you very much. You're doing great. You're doing great. Thank you so much. Khalid. Sheikh Khalid. I only know like three words, and there you go. Anyway, born in the States, I don't do accents very well. But anyway, let's look at surgical execution. Okay, so check this out, guys. So up until that point, almost all of it is the same. Almost all of everything that we've done is the same, whether you're, your BSB, your Straumann, your, BioHorizons, whatever. There's a lot of great companies, whatever you're doing, okay? But this is where it's going to change, right here. So I'm going to spend about literally a minute on it, because this is the part that you should know. And if you don't know, the person selling you the equipment will know. And that's where you'll just kind of get in your one-on-one, lunch and learn and that kind of thing, and go over the keys or the handles, right? Keyless keys, handles, no handles, etc. I just like this. It's a tad old-fashioned, to be honest, but I like the feel of the handle. I like that the handle secures the guide. I've been doing it this way for 15 years, and it's just comfortable for me. It's not the only way, and I promise you it's not the best way, but I'm very happy with my results, so I'm not going to change anything for me. But anyway, so this is where the changes are going to occur, the actual surgical execution, how you put your sleeves in, excuse me, your handles, or do you not use handles, etc. Okay, now, sleeve position. The sleeve position, this is going to directly, proportionally dictate whether you do a flap or a flapless in many cases, because people always say, well, doc, do you do flap or flapless? Well, theoretically, if you are doing a guided surgery, doing flap or flapless has nothing to do with the implant placement. The flap or flapless is really, where is the sleeve? And is the sleeve in a position that you can't do it flapless? I'm going to show you exactly what I mean. So remember I showed you this slide a little bit earlier, and I'm just going to reference this with Straumann because it will make more sense. Okay, I'm not pushing anything, I'm just referencing. So the surgical guide will be made accordingly for your system. Okay, if you're looking for a system, I highly recommend that you get a system that is all ready for your system. Like for me, I said, I use a Straumann implant. I have Straumann drills for my Straumann implant. My drills are marked at certain lengths within the Diagnostix software, so there's no thinking. Now, speaking of thinking, I do want to mention something. Be careful in the verbiage that you have with your patients. I tell my patients all the time about how the procedure is going to be shorter than the alternative, flaps and freehanding and all that. But you have to be very careful. If you say to them, oh, it's going to be no problem, you know what, this should take me like 15 minutes. They're going to feel you're ripping them off financially. It's going to happen. So let me give you a little pearl here. What I do is I say, listen, what I'm trying to do is I'm trying to limit the time that you're in the chair, and I'm trying to limit all the things that will hurt you later. So what we're going to do is we're going to do this guided. Have a guide in your drawer, in your consultation room, and show it to them. Have one that has a tooth-borne guide and maybe one that has an edentulous guide, and show it to them and say, this is what it's going to look like. I'm going to put the implants in their positions that's the safest for you and me. Height, diameter, and angulation. I'm going to figure out all of that for you based on the scan that we took. And the reason I'm telling you that is because I'm going to be spending a lot of time behind the scenes to make the time during surgery shorter. Do not say anything about money. Just let them know. Say, I'm going to still spend a few hours on this procedure, but a lot of it is going to be done with your models and with your scan. And I'm going to put the time in ahead of time and CAD cam your surgery. They know that word. So just be ready for that, okay? Because it will happen and I want you to be prepared. Okay, so I'm going to show you here, you're going to have something that's going to reference on your menu, so to speak. Mine looks like this. You're going to have something that's going to reference where the sleeve is. So for me, it's H6. So that would mean that the sleeve is 6 millimeters above the platform of the implant. I'm going to show you why right now. Okay, so you're going to have different variations of where the sleeves can be. And the reason I'm telling you this is because you don't have to design this. The agent that's helping you, the doctor that's helping you, will help you and give you options. Okay, H2 means that the sleeve is placed 2 millimeters off the platform. And likewise for H4 and H6. Well, what is the big deal about that? Okay, well, there is a big deal, because when we do guided surgery, all guided surgeries are, you know how we do crown down? Well, they do apex up. So what we want to do is we want to start with the bottom of the implant. So where does the implant need to be at the bottom based on the size that you have, the length that you have chosen? And now let's work up. Where is the bone? Where's the tissue, et cetera, et cetera. So essentially, all the algorithms are going to give you the shortest amount of space to put whatever length implant you want in at that length of that red line. So let me make this more clear. You put the implant in virtually, the machine's objective and the doctor at 3D Diagnostics who's helping you design this, their objective is to put whatever implant you think is the best implant, safe and sound to go in there. Then they're going to work up. They're going to give you the shortest handle. They're going to give you the shortest distance from the sleeve. They're going to compress that as much as they can. Why? To make your life easier. So when you have a 26 millimeter drill in your hand, you can get to number 18. Well, let's look at this. So in my case, and if you don't have handles, that's fine. This is going to be a quick 30 seconds. What I'll do is I'll put my handle in the sleeve and I'll drill. And then I'll go to my second drill and I'll drill. And I'll drill to the hub. There's no thinking. I don't have to stop short. This is implant specific. Please do that, guys. Otherwise, it's just not guided. Okay. Sleeve goes in. I drill the hub. See how that bone that came out? This was a site that I grafted ahead of time. Typically, the maxillary jaw is not that dense, but pumping is key, guys, and I'm going to explain why. We're going to do a little bit of pitfalls here in a second. Okay, so let's go here. And then if you need to go wider, you go wider. I didn't need to, but more drills, you know, you have anywhere between 3 and about 8 drills in your kit, and you would just continue on with the next ones the same way. Okay, now, and then ultimately, this is a fully retracted case where, okay, so let me explain why the sleeve is so important, and it's important for all of you, okay? Regardless what kit you're using, you're going to be going through something, okay? And that something is a sleeve. Now, if you look here, this is telling me, hey Dr. Engel, if you want this size implant in, and you want it positioned right there, then if you choose the sleeve at H2, look what happens. It's going to hit bone. Well, I can't do that. The patient has tissue and the patient has bone. I can't have it rocking on bone. So that won't work. So an H2 option is not a good one. Now, let's see what it looks like with an H4 option. Well, that's a little better. That's a little better, but I've cleared bone, so it won't rock on bone. Now, what you're looking at, this blue thing, is the cross-section of the denture, okay? Between the denture and the bone is tissue. So I'm asking you a question rhetorically. I can't hear an answer, but I would like you to answer. What is this green thing hitting? This is the cross-section of the sleeve. This is the front of the sleeve and the back of the sleeve. What is that hitting? Well, if you're saying it's hitting tissue, you're correct. Now, my question is, do you go to the H6, which is 2 millimeters further away, or do you stay here? Well, I don't know. In the back of the mouth, I'd be highly inclined to not go higher with my sleeve. Why? You should know that answer, because you might not be able to get the drill in there. So then I would say, well, do an H4, but what would you have to do? You would either have to flap the tissue away to get it out of the way, and then it won't rock. Or you get a tissue punch that's bigger than 5 millimeters, and you do a tissue punch first with a 6, then you seat the guide, and the punch is bigger than the sleeve, and so it won't rock. In the back, that's where my go-to would be. I would rather punch the tissue wide and not have that extra 2 millimeters of drill height, if you will. Now, if we look at the H6, this is different. So this H4 is showing you that it's still hitting tissue. Now, if you look at the H6, here's the sleeve. Surely not hitting bone, right? surely not hitting tissue, we're all clear. Now, if you're working in the anterior where space is not a problem, it's a luxury, then I would do that. I would do it fully, I would just punch it and I would do a case like that. So that's why sleeve height and sleeve position matters. The closer the sleeve is to the implant that you've designed, the easier it is for you with your drills. This is going to require a very, very long drill to get from the top of the sleeve to the apex of the implant. Very long. So when you go in the back of the mouth and you try to stand that up straight down like a drill press, you're going to have a very hard time. And I'm going to tell you, if you can't get it out, you and your patient are going to panic. Okay. Then for me or for you, I'll just show you this, and then we're almost done here. You would then go to choosing a drill, and in my case, the specific implant site is telling me to use my medium drill. And then for me, I also have handles. So it would say, hey, for you, we want you to use the one size handle, and you could see here, my handle has, handles come in all types of different forms, but there's one dot right here. I don't know if you could see it, it's a blue dot. And so I would just put the handle in with the one blue dot as instructed, and then I would grab the number 2 line drill and I go to depth, and now I know everything is controlled. Okay, there's the handle. That's the 3 side, not that that matters. Okay, so let's talk about a couple pitfalls and then we'll end it. And thank you all so much. We still have a nice big audience here and I really appreciate that. Okay, so this is an interesting case where I saw this patient. She had had number 8 missing for about 3 or 4 years. And this is another reason why I'd go guided. You might ask yourself, especially if you're listening to this and you've done a lot of implants, well, I'd freehand that one. Well, yeah, so would I. But I'm gonna tell you why I didn't. Because this patient had been missing this front tooth for 3 to 4 years. And what do you think happens with space when the patient is missing the tooth? Yes, you've guessed it right, closes up, right? So as you could see, this white tooth is much smaller than this green tooth. So what we decided was, we decided that we wanted to try to make the 2 front teeth even. So my conversation with the patient, and I'm hoping you're thinking about this, was, hey, listen, this is your front tooth. This is much more narrow than this front tooth. So the best approach towards this would be an implant and a crown on this tooth and something like a veneer. It was a really nice tooth, so I would choose a veneer, be a little tiny, a little bit extra aggressive so they look the same, especially in the front. Different game show. But I said, if I can do a veneer on this tooth, what I can do is I can slenderize it a little and I can give space to this tooth and make it even. And that's exactly why I did this case guided. Not because I didn't have enough bone, not because I didn't have enough tissue. Contrary to that, you're gonna see it was great. So here's the guide. Sorry. Okay, so let's look at this case. So here's the CBCT. What you're looking at is the system that I use has what's called a 3D pan. So it's kind of, you take the old that you're used to and you bring in the new, meaning the old, you know, we're all used to looking at panos. And if those of you are new to cone beam, you get that pano and you also get a couple cross sections. And the way that that works is this green box moves wherever you want it. And the red line goes on the long axis of where you want the implant. These little blue circles, you can tip the box so you can get the true line of fire on the implant. Okay, so this is going right down the middle of where my implant is. Here is the cross section, the one right in the middle. Okay, good. So now what we did was we measured from this lateral incisor to this lateral incisor, and we had a total of 18 millimeters. So we were gonna make each tooth 9, which meant I had to trim this tooth down a little. Now you don't know how to do this, and I promise you this, I don't either. But what I'm gonna say I don't know how to do. In the software, Dr. Epps trimmed this tooth virtually to make it 9 millimeters. So if you look here, this is a 9 millimeter tooth. This is our existing tooth. And the new virtual crown over the implant is also 9. So that implant is positioned not in the middle of the space, but in the middle of where the tooth is going to be, because I haven't veneered it yet. So let's look. So here's the plan. Little anatomy test. What is this? The nasopalatine, correct. So the implant is placed very, very safely. This outline in pink is the gum tissue. Here's the tooth in white. The green is the sleeve. We want the implant coming right through the cingulum. This is placed really, really nicely, virtually placed, right? Now, Here's my final. Very, very happy. Very, very happy. The positions were 12 1,000ths of a difference off. We measured them. The only reason that this may look a little deeper is because this has a closure cap or a cover screw on it, but it is exactly 12 1,000ths away from the plan. This is good. Now I want to tell you something, guys. When you look at any x-ray, do not comment on implant position, because you may be saying something that's inaccurate, even on your own cases. If you take a PA and one, let's say one was an inexperienced surgeon and didn't understand, and they took a PA and they were looking at the implant, it would superimpose the nasopalatine foramen, which is right here, and you might say that implant is going right into the nasopalatine foramen, when indeed it's not. And you can clearly see that it's anterior to the palatal foramen, which is way back here, a good 5 or 6 millimeters away. Okay, great. Uh-oh, pitfall. 140. Pitfall. So here's the implant at 30 days. Now, I'm not going to explain why. I do grafting courses and all kinds of courses. You can look me up and I'm going to tell you when I save these and when I don't. But anytime I have, let me go back, anytime I have at least 1/3 of the platform in clean, good bone, this is something that I'm going to save. Now, there's 2 reasons that you would have an apical lucency like this. 1 would be perforation. 2 would be what I'm going to show you that happened to me. I did not perforate because we saw that right here. I'm in the bone. So let's go forward. So what I'm going to do is I make a peri-apical kind of an apicoectomy. I open this up. I clean all around here, everything. Do not worry about touching the implant. It's already decontaminated. Obviously, try to stay clear of it, but clean anything that wants to move, clean it away. Then I don't show it here, but what I'm going to do is I'm going to take tetracycline 500 tablets, open them up, add a little bit of water to make yellow water, put cotton pellets in there, tetracycline 500, open them up. Put them in a dappen dish, put cotton in with water, put those yellow pellets in there all around it for 5 minutes. Leave it in there for 5 minutes and then irrigate the bejeebers out of it. Irrigate with sterile water. Don't use your bracket table water. And then we're going to graft it. As you can see here, I used a Straumann allograft bone 80-20 combo, and then I used a resorbable membrane. And then, so this I call a successful repair. On your immediate left, that's the day we put it in. On your immediate right is the lesion, and that's the same day, the center one. So you could see that we've obliterated the lesion. But here, more importantly, look at this. What you're looking at here is 90 days later. And this is the patient healed 90 days later. There's no evidence of any flap. If you look here, you have 3 millimeters of facial plate directly in the, which would be right here. This is the 3 millimeters. This is all of the bone that we grew back. And then if you look here, well, if you look here, you could see that there's a white line right here. From here to here, this is all new bone. So there's a little faint white line in right there and right there. So you can almost see a block of new bone. So we're very happy with this. And here she was at the very end of the case. I'm not thrilled with the case, but I think we did really well. She flew in from Nevada, and I had 1 shot at a front tooth. I was sent an impression and a photo. I sent it to my lab, and we did the best that we could. She gave me 1 chance. So it's okay. It's not bad. This tissue right here is just because we opened it up that day to seat the crown. But I've seen her since. This is quite a while ago, and this all looks really nice. And we did okay. Not bad. Okay. To leave you with this, because this is where dentistry is going, I do quite a bit of these. I do about 50 or 60 a year, and I love them. It's absolutely fascinating. It gives you a high that you can't even imagine. And right here, it says life-changing. That's exactly what it is. It's a good friend, Brent, not a good friend, but a good patient friend. Basically, reduce the bone, put my guided implants in, put my abutment guide in, which 3D Diagnostic also provides. The green lines are indications of where you want screw holes coming out. Here is all of the pre-cut titanium abutments that are also provided in this kit from 3D Diagnostics, as well as the silicone chamber. And what we go ahead and through several processes, we make a PMMA. And this is a surgical repositioning of the flap. I do classes where we do 12 live patients and 12 doctors, and everybody does a complete case of one of these. And so here's Brent now, immediately after surgery. Okay, guys, I want to thank you. Let me go back a second. I want to thank you very, very much. Truly, I know that we spent an hour and 45 minutes. It was about 15 minutes longer than I expected to run. I wanted to give you the most that I could in the time that I had. I wanted to be efficient. I wanted to be articulate with as much as I could. I realized that there's different levels of surgical intellect. I realize a lot of people have done some have not done some. You all use different instrumentation, technology, implants, etc. So I really, really love what I do. I hope that I made a difference for you today. Again, you can reach me. The best place is Instagram at Todd Engel DDS. I'm on it. It's the easiest way for me to communicate. You can also go to Engel Institute Dental Implant Training if you feel like you want to learn something. There's 4 fantastic modules. I'm a big fan. If you go and read about them, I think you'll enjoy them. And then I think I'm going to just once again thank Mr. El Said, who's the CEO of 3D Diagnostics, all my friends at 3D Diagnostics, who are just fantastic people, all my supporters, all my sponsors. But for today, honestly, guys, I want to thank all of you. It's meant a lot that I've been able to do this during this downtime. It's what I love to do. So thanks for being my audience. God bless you guys. Take care. Thank you. Frank, we're going to do Q&A now, buddy, if you want to take over.
Dr. Engel, fantastic lecture. Thank you so much. A few Q&A for you. First of all, a couple of questions regarding which reline material do you usually use, and which denture marker beads do you usually use for your dual scans?
Hang on one second. I'm trying to figure out can you guys hear me now, Frank? Frank, can you hear me?
Yes, I can. Can you hear me?
Yeah, and can you see me? I don't, because I've shifted. Can you see me?
No, I can't.
Can you now?
Yes, I can, Dr. Engel.
You can see me and hear me.
Fantastic lecture, Dr. Engel.
Yes,
a few questions for you.
Yes, sir.
First of all, a couple of questions regarding which reline material and which glass beads or marker beads do you use in your dual scans?
Yeah, great question. So, so the material that I use is a product called Mucopren. It's made by Kettenbach, and it's really fantastic. I've used it for a long time. I use it on all of my cases, and more importantly than just being a good liner, and there's a lot of good liners out there, but when I find stuff that works, I just tend to stick with it. That's just my style. The other thing is it's outstanding on tissue healing. So I see 48-hour post-ops that I just shake my head at. It's got a few properties that are intellectual properties in the material that work on tissue. And there's a lot of times I can't believe my eyes. It looks like 2 weeks post-op at 48 hours. So that's the material I use. Mucopren by Kettenbach. If you tell your rep, if you look up the company and you tell the rep that you heard this, and tell them that you want an Engel special, they usually do a nice break. But I realize that there's a lot of people, a lot of sponsors that are part of this that have great materials too. And I'm not just saying that. There are a lot of good materials out there. Part 2, the question was the glass beads. I believe I showed it in the lecture. I've been using one type of bead. It's the Sure Mark bead, the 1 millimeter diameter bead that I get from 3D Diagnostics.
Thank you, Dr. Engel. Another question is, Dr. Paris Donastrog, he wanted you to explain again what you did with the apical case and the tetracycline.
Okay, that's always the one that gets everybody. Okay, I'm having a problem going back, so let's tell you. So really quickly, if I place an implant and I see that I have an apical issue with the implant, I'm going to first decipher why. If it's a perforation, then what I'm about to tell you won't work. You have to reposition the implant, take the implant out, whatever it is. Once I've identified that the implant is indeed in the bony housing, like I showed you in the post-op scan, then I know, and excuse me, because I didn't even tell you why that happened. So thank you very much for the question. So for all of you guys, the reason that happened, it was one, I would say 99% related to heat. So we want to make sure that we do continuous irrigation. My bad on that one. This one, if you can identify that the implant is indeed located in the bony housing and you have that at the bottom and you don't have it at the top, you can pretty much rule out compression necrosis, which happens typically around the platform. If you have a nice clean circle at the bottom and the top is good, that typically means heat from the drill. So pumping action is good. Pumping, pumping, pumping. And what we do is we use a monojet syringe full of sterile water after each drill. So that's to help prevent heat. I don't see a lot of it, but you have to be very conscientious of it. Okay, now that we have this granulation tissue, guys, it's not infection. This is not infection. There's a difference between infection and granulation. Granulation is the growth of soft tissue, and it migrates connective tissue, epithelial tissue, everything migrates in and disturbs the implant. When we're talking about an infection, we're talking about separation. We didn't have that. I would have removed the implant if we had, okay? Now, why did I do what I did? Because you have a contaminated site, not an infected site, a contaminated site. So objective number one is to remove anything soft. If you leave a little bit behind, the majority will win and it will be fine. But I'm very, 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 very particular about what I use, instrumentations that have curves, etc. And I'm going to spend a good 10 to 15 minutes cleaning because the more soft stuff you get out, the better off you are. Now we're going to irrigate it, okay? And then we are going to open, here's your question, Doc, a 500 milligram tablet of tetracycline. It's going to look like, literally like a pixie stick or yellow powder. Put it in a dappen dish. Put in some sterile water, you can use saline too, and mix it up so you have yellow water. Put in your cotton pellets. The less water that you have to put in to saturate it is better, because then you'll have more potency from the antibiotic. Get yellow clumpy cotton balls and shove them in around the implant threads, all the way everywhere where you can reach, and put them in and leave it in for 5 minutes. And what you're going to do is you're going to decontaminate. It's important you understand that. You can't sterilize anything in a patient's mouth. You can decontaminate it, okay? So we are decontaminating it. We are essentially opening up some new cellular activity. We are going to irrigate a lot. I want you to irrigate about 2 or 3 monojets full. And the reason I want you to do that is because this can burn, okay? Because it's very acidic. Then you're going to graft. Then you're going to place your restorable membrane, resorbable membrane. And the reason that you want to do that is because you don't want to have to elevate tissue. The membrane should exceed the bony margin defect by 2 millimeters. And then we're good to go. The membrane will contain the graft. It will isolate the epithelial invagination. And in about 4 months, you'll have what you saw. Mine, I got in 3. Okay, hope that explains it. Thank you. Frank, question?
Thank you, Dr. Engel. Yep, 2 people were asking the same question regarding, one regarding the failed case, the one with the implant ending up in the palatal bone.
Huh?
Can you hear me?
Yes, I can.
All right.
What is the actual?
Basically, the question is, how often do you end up taking cone beam CT during or after any implant surgery?
Yeah, it's a great question. So number one, I take them routinely. The only reason I wouldn't take one is if you're pressed for time and I felt really good about the case. But there's an asterisk to that, okay? You have to make sure that the cone beam machine that you're using is FDA approved for a post-op scan, because a lot of machines are not. They are only approved if the patient has symptoms. Well, the patient's not gonna have a symptom 30 minutes after a procedure because they're numb. So check with your CBCT manufacturer and see, like on mine, I have an ultra low dose. So I can scan children and I can do post-op scans. So you wanna make sure before you go post-scanning everybody and everything that you are FDA approved with the machine and the technology that you have to do so. If you want to Instagram me, I'm not trying to push that. I'm just saying I can answer more questions. I'll tell you how I do it and what I do. But I am FDA approved to do that. So I would recommend that if you're looking for a CBCT, that you definitely check that box, that it's FDA approved for a post-op scan and children.
Thank you, Dr. Engel. One final question. If you're doing a sinus bump procedure, do you use your osteotomes or autotomes through the surgical guide, or do you freehand after drilling? Could you speak about sinus bumps and surgical guides?
Of course I can. Come to mentoring 2. No, yes, absolutely, or 3 or 4. But no, let me answer that because that's a great question. They're all great questions. And by the way, if we don't get to yours, we will. I'm going to go through the questions. I have a few days off, you know what I mean? Okay, so what we'll do, and Dr. Epps, who you're hearing on the phone with me now, is actually the individual who does my guide design on that side. So what we will do is we will place the implant exactly where we want it, but we'll make sure that the apices is at the floor of the sinus. So in some cases, the platform's out of bone a little bit. And there's a couple different ways to do that, but that's how I do it, because I want it to be able to drill all the way to the apex without worrying that I'm going to get into the sinus. So we plan our apice of the implant just below the cortical plate of the sinus cavity. And we drill, and we don't really worry about entering the sinus. From that point, what we'll do is we will drill a couple drills wide. I will then, through the guide, get my autotome, which is phenomenal machine. It's like one of my 3 to 4 favorite pieces of technology I ever have owned. And you should go to salvin.com and look at the autotome. It's amazing. They also have periotome tips. But anyway, what I'll do is if I ended with, let's say, a 4.2 millimeter drill, then I will go to the autotome tip that's right at about 4.2, and I'll go in the center, no handle. I'll go into the center of the sleeve, and I will go to the depth that I need to lift the sinus. And if any of you remember the game Operation, where you would try to get things out of the little guy's body, and the objective was to not touch the walls, otherwise it would buzz. It's kind of the same thing. So I keep the autotome right in the middle of the sleeve, and I make sure that the space is equal all the way around, and you're going to be just fine. Thank you. Great questions. Appreciate that.
Thanks again, Dr. Engel. For anyone who did ask a question that was unanswered, we will send Dr. Engel all the questions, and he will answer as much as possible via email. Again, thank you, Dr. Engel. Thank you, everyone, for attending. Regarding your CE credit, since it was a 2-hour lecture, it will be 2 CE credits. Please go to 3ddx.com/CE and use code 10G01. So it's 10 TEN G01. And then enter your AGD number if you are an AGD member, and leave it blank if you're not an AGD member. And of course, please make sure to sign up for the upcoming webinars on 3ddx.com and check engelinstitute.com for upcoming courses, hopefully when these difficult times pass. Thank you, everyone, and have a good night. Stay at home and stay safe.
I wanted to mention one more thing. Thank you so much. I really appreciate that. Thank you all. Thank you. Guys, I want to mention something just for a second off the webinar thing. Just know that this is a really hard time for everybody, and know that we are all in this together. So just make smart decisions for yourself, make smart decisions for your family, and just be safe, stay safe, make moves that are good and important for you. Be selfish at this time. Make good moves that are for you and for your family. But here's the thing. When we come back and we are given all of the freedom that we don't have right now, Starbucks, football games, eating dinner at a restaurant down the street, let's all learn to be a little bit more compassionate to each other. We have a wonderful life. We have a wonderful country. Let's start showing a new type of a compassion to each other. I definitely will myself. So that being said, during this tough time, I want to wish you and your families the best. Stay safe, be smart, make good decisions. I really appreciate your time. Thank you guys at 3DX. Good luck to all of you.
Thank you. Bye-bye.